Okay, welcome everyone. This is our second talk about. Actually, we are doing the case studies. We started, I think, 2 weeks ago. The first one was about pericarditis, acute pericarditis. Actually, it was a good case. It wasn't a fully real one. We got the vitals and everything from website. It's called Medscape. This is for the first one, but this one is actually based on a real patient. It was in Italy in 2017, I guess. Uh, and actually, it's so much interesting case. I made the search about it. I found a lot of values and like a different aspects regarding this case. So we will get dive on it, and you will see about it. So I will start about the case. This is the first presentation once it came to the clinic. So it said an 87 years old woman presented to the ER with a worsening shortness of breath, fatigue, and progressive dyspnea over several days. No fever, and there is no cough. Past medical history is unremarkable. No known cardiopulmonary disease. Denied chest pain, leg pain, or swelling prior to the admission. So was the first time the case presented to the emergency. Um, uh, Actually, there is no a lot of details or like past medical history about it, since like it comes to the emergencies. So we need to to manage it quickly. So you see in front of you, that's the presentation. What do you think about the physical examination? I will show the next slide about what they've done for this patient, but I want to get like some ideas about you. Like, what do you think the first physical examination should we do? Should we go directly with the management, or should we do a kind of specific physical examination? Any ideas?
In which
Lungs.
consultations,
Okay, auscultations.
see what kind of reasons and what.
Yeah, totally correct. What else?
Uh,
Do you think that like there is something prior to do before we do physical examination?
then
As I said, like, do you think that we need to do something before the physical examination? Like, since it's an emergency case. Yeah. Sorry? Sorry, I can't hear you. If you can. Yeah. Yeah. Okay. So we need to stabilize the patient. First of all, we need to check the vitals. Like we check the oxygen saturation. Yeah. And for example, the heart rate, the respiratory rate. Okay. What else? You said lung examination checks the vitals. Do you need to do something else? Do you think? I mean, we have dyspnea, and we have shortness of breath and fatigue. Could it be a cardiac issue? So,
it
yes,
says no cardiopulmonary disease.
this is. I mean, my prior to the admission, so we don't know.
History?
Yeah, so maybe right now we have the disease. We don't know.
Okay, okay.
You got me.
Understand.
So there is no history of cardiac issue.
So always, yeah, you want to check the heart as well. You want to see if it's.
Yeah, so we do a heart examination and lung examination. Yeah, ECG also, that's super important. Okay, I think you mentioned most of the stuffs. Vitals, once he came to, I mean, sorry, she came to the emergency. The respiratory rate was at tachypneic, so there is no specific value, but by much she had the tachypnea. The saturation was low. We had the heart rate and the blood pressure was normal. And the ECG, actually, that's so much interesting. There is a sinus rhythm and present of P waves, right bundle branch block. Okay. General was good. Lung auscultation, we had a bilateral bibasilar crackles. The cardiovascular was regular rhythm, no jugular venous distension. That's also something interesting. How we had the ECG bad and we had a good physical examination of the heart. The extremities, we had an ankle edema. Okay, a good distal perfusion, everything was normal. Neurologic was good. So, based on this physical examination and the presentation, uh, I mean, as we done the first case of study, wherever we approach the patients, we need to form our like differential diagnosis. So we don't go back to the history again. We don't go back to the physical examination and check and take this one. We need to form our whole differentials. We put the first one as the priority one, the high one, and then we go more lower, more like excluding the other diagnosis. So what do you think your differentials would be in this case?
seems like early sign of heart failure.
Okay, that's good. Yeah, we had a bad ECG and also we had ankle edema. Yeah.
Ankle edema and all that. Dyspnea is also a good sign.
Okay, congestive heart failure could be a part of it.
Crackles in the lungs as well for the pulmonary edema.
Okay, could be also pulmonary edema, could be the case also here. What else?
Can we go back to page? Can we go back to pages and
Yes,
so we can see that?
of course. Any ideas, others? Actually, it's so much tricky, this case, because we had also a bibasal crackles.
Yeah.
So what else could be?
What's RBP?
The RBB is like right bundle branch block. You know the heart. You have the right bundle branch wants like the conductive system want to work to pump. This bundle branch is kind of like we say, not disrupted. So it shows in the ECG like this. There's a specific pattern for it.
Okay, so clinically does it mean like there's hypertrophy, like sinus rhythm disorders?
Still, we don't know this. We need to do echo. So that's will go with the case. So basically, once they present to you, the ECG is the fastest thing. Sometimes echo needs like 1 day, so we don't have echo. Yeah.
Could it be pulmonary embolism?
It could be,
Yeah.
could be.
Okay. Yeah.
Yeah. So right now we said congestive heart failure,
Which is a heart failure.
pulmonary embolism.
Pulmonary embolism.
Also, we said pulmonary edema
Pulmonary edema.
and no other
Could be
differentials.
atypical pneumonia.
Could be atypical. Could be. That's a good one. That's a good one.
There's no fever.
Okay.
Interstitial kind of one.
Yeah. Interstitial.
Interstitial what? Diseases? You mean interstitial lung disease, like lung fibrosis? Okay, that's a good actually workup. So interstitial pneumonia is the priority one in this case. Yeah, there's no fever. The presentation looks actually so weird. Pneumonia is not like this, so it could be atypical. Also, we have interstitial lung disease. Yeah, as I said, we had a bibasal crackles. Also, we had an ankle edema and a right bundle branch block. Could be indication of interstitial lung disease. Congestive heart failure also.
Yeah.
Yep. But it's kind of like we put it lower because the physical examination.
Because there's no angina.
Yeah, there is no. Also, the physical examination was normal for the heart, so it's kind of further out. Lobar pneumonia, it's a little bit far. We didn't have that. Yeah, we didn't have like a. Yeah, there's no like a consultation or something like this to say it's a lobar pneumonia. Pulmonary embolism. This is also one of the differentials.
There's no tachycardia, right?
I guess no. Yeah, the heart rate was normal.
No tachycardia.
Yeah, it was normal. Yeah. So pulmonary embolism. Yeah.
So,
You kind of lower it because of there's no tachycardia. You are correct in this case. And ARDS, I think that's so far because the patient, but still, the patient is 87. They have bibasal crackles. Could be ARDS. We don't know how much the duration of those diseases. So now comes the workup. Since you had your differentials, you need to order your like your labs, your imaging. You don't order like each one separately in the clinic. So based on this differentials, what do you think we should order in this case?
Chest X-ray.
Just X-ray. Okay. What else?
Just CT.
Just CT because of interstitial lung disease. Yeah, correct. But we found that the patient had a lower saturation, so we should start with something, an oxygen. Oxygen. You should order an oxygen also. Because most of the time, yeah, the emergency, the EMS, they will bring the patient with the oxygen, but sometimes they miss this. So you should order also an oxygen. What else?
how much saturation?
Well, there's no value, but it said it's low. It said it's low. I tried to search, but in the case published, there's no any value. I don't know why. Also.
Maybe like meters, like that one.
Okay, that's a CMP, I mean, which is a complete metabolic panel. Yeah, to check for the kidney, check also for that's also correct. We will see if they order it or not. What about ABG, like an arterial blood gas? Arterial blood gas, like to check the PCO2 and BO2 is also important. We said also chest X-ray. We said the chest CT. What else? Also, we ordered I think in echo because we have a congestive heart failure, so we need to check this also. Um, I think that much, but let's see what they ordered for the patient. We ordered an oxygen, an ABG, also a CPAP. CPAP to basically if you have the patient who had kind of like a picture of a pulmonary edema or like an ARDS, you should order CPAP, and that's something in the emergency.
Positive area.
Yeah, CBC also CRP. We don't know. Maybe it's an infection, so we need to order CRP too. It's
Interstitial disease kind of is like related to CRP.
yeah, yeah, exactly. Chest X-ray, chest CT, blood culture, and urine culture. Because we don't know. Maybe that's sepsis.
It's not the hemoglobin.
Hemoglobin is under CBC. CBC is a complete blood count. So you will have hemoglobin, you will have MCV, MCHC. Uh, so like in the clinic, you cannot order hemoglobin alone and MCV alone. No, you put all of them under the CBC. And under CMP, you will have calcium, glucose, and sodium, potassium, magnesium, all of stuff related to the kidney. There is something else called BMB. BMP is different than CMP. You don't see calcium and glucose in it. It's more faster in this case. Uh, BMB is also important.
BNP.
Do you know what's BMB?
For congestive heart failure.
Yeah.
Naturally.
It's called BMB. Do you know it? Do you know what does it stand for?
It's for natriuretic peptide. So,
And the B,
B is brain.
brain.
The
Yeah.
natriuretic peptide.
I mean, it's so much weird the name that they gave it to it, like brain. Why? It's related to the heart. Why
But
they
there's
call?
also ANP, which is atrial.
Yeah, the atrial one. Yeah.
That's one you look at for congestive heart failure. But also BNP works as well.
The AMP usually it's in the atrial walls, so it's not. Let me say it's not specific for the congestive heart failure compared to the BNP because sometimes maybe you have an overload and you still have a high AMP, but BNP will be only high in case of congestive heart failure because it's also in the ventricles, so it's more
So you
better.
look at BNP for
Yeah. You will never find someone order A and B because they feel like it's not accurate. Yeah, B and B
You
is
always see BNP, not ANP.
Yeah.
You always see BNP.
Yeah.
So I think for monitoring is more than
for monitoring also. Yeah.
monitoring more than diagnosis.
Yep. Also, we have lung ultrasound, and I was actually impressed in this. First time I see lung ultrasound. Yes, ordered. One of
Have
the
you seen, like,
steps.
blood flow, like TB or something?
It could be show you, but I think they ordered for something else.
You get inside, like
That's actually so much more interesting in this case. You'll see. Also, chlamydia, IgA and IgM. Well, we said our highest differential are atypical pneumonia.
So,
And atypical pneumonia are caused by three pathogens. One of them chlamydia.
it's chlamydia, sure.
Yeah, chlamydia and Legionella and
Mycoplasma.
mycoplasma. Yes. So that's why they ordered IgA and IgA.
Why are we checking molecular?
Hmm?
Why are we checking molecular?
Because you want to know what is the cause if it's atypical pneumonia. You want to see which organism is causing it. Because according to this, you will give an antibiotic.
With Legionella and the Mycoplasma, you probably also see.
You said Legionella.
like he asked me why they specifically go chlamydia, for example.
This is actually one of the discussion questions. Why they only go with chlamydia?
For example, if there was sputum production, we can do sputum culture.
Yeah,
It will have been
yeah. We will discuss this. Okay. So the labs came with the normal CBC. Weird. C-reactive protein high. How? I don't know. BNB was high, 248. And here we start to get confused, like, CRP high, infection, then heart failure, then normal CBC. What the heck? What's happening here? The arterial blood gas, the ABG was PCO2 was elevated and PO2 was low. So this is a picture of lung disease. Okay, so lung is not working. So there's a high CO2 and there's a low O2. Blood cultures and their culture was negative. That's also weird. CRP is high, blood culture are negative. We have a high PMB, ABG is bad. The last one was a serology, chlamydia was positive.
Yeah.
So like a dead giveaway for atypical pneumonia. Chlamydia is positive, okay, and IgA is so much high. But I mean, still, sometimes it's not a specific 100% to say that's also, I mean, only like interstitial pneumonitis could be something else, could be in sepsis in the blood leading to a heart failure. So we need the imaging. Imaging will lead us. The imaging, chest X-ray show a diffuse interstitial micronodular pattern suggestive of fibrosis. How? That's a picture of interstitial lung fibrosis. Okay. The lung ultrasound, okay, which is the weird one. Irregular coarse pleural line. I know you start to shake your head, it's like your head, you don't understand anything. Multiple bilateral B lines with no spared zones. There is a small subpleural consolidation, okay, which is 5 to 7 millimeter in the right mid lung. The echo was normal. CT show a tree in bud pattern. So tree in bud pattern, that's a dead giveaway for interstitial pneumonitis. The chest X-ray kind of showed the picture of lung fibrosis and interstitial pneumonitis, but it's more for lung fibrosis. But the CT confirmed he had interstitial pneumonitis. The ultrasound was so much like interesting. It showed irregular, coarse pleural lines. So it kinds of infection in the pleural line, not in the alveoli itself. This is confirming interstitial pneumonitis. Multiple, we said bilateral B lines. I will show that those B lines are so much interesting actually in the end of it. So the diagnosis was severe interstitial pneumonia caused by chlamydia pneumonia. The treatment from the first day, they admit the patient to the IM ward, the internal medicine ward. We will talk about this also. Like there is a specific criteria for the admission to the patient, and they need some. I mean, some of the values to like to decide if this patient need to be admitted or not, and they didn't in this case. So we will discuss about this. They admit them at the first day, respiratory support. They start CPAP, required for resistant respiratory acidosis since we had PCO2 high and low O2. They start azithromycin, 500 milligram daily IV. Azithromycin is used for interstitial pneumonitis, but still we don't know like what is the pathogen 100%. Yeah, chlamydia is positive, but still you need to start something more wide spectrum. And yeah, and according to the sputum culture, which is they didn't took, I don't know why, and the PCR, you will decide to change, but they start azithromycin like this. Community acquired pneumonia, but like which pathogen we don't know 100%. That's why. At the day 10 after the admission, after 2 weeks, the patient got good, blood gas treatment normalized with a low flow oxygen. Patient transferred to the rehabilitation. Progressive improvement in the clinical state and blood gas exchange was good. So everything was good with azithromycin, only azithromycin, okay, for 10 days. The follow-up imaging was with an ultrasound, which is was one of the interesting thing in this case because the role of ultrasound in the management also showed a progressive regularization means get back to its own my normal structure. Uh, some reduction in the B line, which is we discussed in the ultrasound, and also appearance of the subpleural consolidation. The differentials here. The differentials was CHF. It wasn't the diagnosis because we had a normal echo. The echo was my normal plus. The interesting thing, we had the high BMB was around 234, I believe, or 40. Still, it needs to be more than 300 to say that the patient had a congestive heart failure according to the BMB. So it's still in the lower part.
It's more about monitoring, not
Diagnosis, yeah, correctly. Lobar pneumonia, it wasn't the case because we didn't had any fever, no cough, no. I mean, also the CBC, the CMP was normal. Also, the CBC was normal for white blood cells. The CT didn't show a lobar pneumonia, so this is not the case. Pulmonary embolism, we don't have a lot of risk factors. Yeah, she's a woman and she's an older I believe 87, but like still, I mean, there's no there's my criteria. It's called Wells Wells criteria, which is for the pulmonary embolism, the score will be around 1 or 2, so it's not that risk in this case. Interstitial lung disease, no. Still, we had our CT was good. Plus, this wasn't acute. This was in a couple of days. So, interstitial lung disease. Think about months, smokers uh, who who like to have a progressive disease. The first time they come here with only cough, then start with dyspnea, then start with
Occupation.
also like occupational diseases. So it's not the case here. ARDS, it's so much far. It's not like something acute. It's more acute. I'm not sure. You have a question?
Something like,
Yeah.
if it was a chronic problem, like it was chlamydia, shouldn't there be like stuff coming out of the genital place and going down, like going to the toilet?
You mean a genitalia infection?
No, like you said it's chlamydia, right?
Yes.
If it's chlamydia, there should be like other signs, especially if it's chronic, like you're going to the toilet, there should be bonus. Or there should be like stuff coming out of genital place.
I got you. But right now you are talking about chlamydia. There is like three types of chlamydia. There is chlamydia pneumonia and chlamydia. The other one, what is it called? Trichomonas. So the one which is called the urine infection are chlamydia trichomonas, not this one. This one only by pneumonia.
Can you do visual field?
Yeah, there's different types of chlamydia.
There's different
I
types.
don't know.
The way you're thinking of is different than the one.
No, you're totally correct. Yeah, I mean, it could be, but the chlamydia that we have, it's actually it's only pneumonia. So if you have the chlamydia, which is you talk about, you won't have any lung symptoms. You will have like urogenital symptoms. Sometimes you have a rash in your skin. You will have a joint pain, but not lung. Lung is only for pneumonia, chlamydia pneumonia. Now comes to this, actually the discussion about the case stuff which is they done. We don't know if it's correct or not, but the case was good because they bring the like a case which is I don't think you will see it a lot in your clinic, and like an old lady present with an atypical picture, no fever, no leukocytosis. You won't see this case a lot in your life. But the discussion, we will talk about some questions that we will see, like why they didn't go with it like this. The first question was like incomplete laboratory evaluation, which is you mentioned, didn't get the CMP. I don't know why, because we need the CMP if we want to admit the patient, because we have a kind of score we call Corpus 65, which is the CURP, then 65. If the patient is older than 65, that's a 1 point. If the patient has a confusion, that's another point. And if you have a high urea, and you cannot say that they have a high urea without the CMP. So that's something weird. I don't know why they didn't order it in this case. So we need CMP. That's
Study rate also. Study rate should be high.
yes, but I think we had it in this case. This is the carb 65.
How much was the study rate?
There wasn't a specific number.
It's like it,
Yeah, just make kept name only.
it's in the-
We don't want to put values in way.
No, no.
I think they missed the numbers. Okay, we have a confusion.
Right.
Bun, the high bun, respiratory rate high, as you said, and a low blood pressure, which is they give you a picture of like a sepsis and age more than 65. High respiratory rate was high. Also, we had a older than 65, so it fits the criteria for the admission. But we need the CMP for the bun, so it's not something you should miss in this case. The second question was about the microbiological, which is you mentioned. Why they only took mycoplasma? I mean, Legionella also can cause it. Plus, mycoplasma most of the time it's for children. It's not it's not an adult. It works here that it's mycoplasma. I mean chlamydia. But the most common one in adults are yes, Legionella and also mycoplasma, not chlamydia. Chlamydia pneumonia is seen in children, not in adults. But that's an atypical case here. So they should order the three serologies, and they only ordered the IgA. I don't know why they didn't order the PCR, the sputum also. That's weird. The third,
No, sorry. There's no GI symptoms for Legionella, for example. There should be GI symptoms.
for what?
Legionella.
Yep. Yeah, maybe like that's why they didn't order. But like still like sometimes you may have Legionella without any GI symptoms. Also, the CMP will show you if it's Legionella or not because the sodium will be low.
Yeah.
So CMP is so much important in this case, and they missed it. I don't know why. The is there other question?
No, I'm just saying they missed it.
Yeah, they missed it.
Yeah.
And the third one is the atypical presentation. Patient was 87 and no fever, no anything. That was actually one of the questions. So we should take care of those patients because the picture looks like a heart issue, but it's a lung. So that's important. Here's the ultrasound. Ultrasound is so much interesting in this case. I mean, once you see ultrasound, you think about stomach. I don't know, like an abdomen, appendicitis, those stuff. But here for the lung.
It's not bad. Where's the
Okay.
B lines?
Sorry,
Where are the B lines?
where is the B line?
Exactly, B lines.
Okay, where is the B lines? This is the normal one.
This is normal.
Yeah, you don't see the B lines.
This is B
The,
line.
yeah, the B lines it's for like when the fluid is like stuck in the pleural space. I will show. I think there's another picture in the coming slide. If if we have the A line, this is for the air. So if the air is like inside the pleural space, you will only see it like this. But if there's a fluid, you will see the B line. So as a one line like this. I will show a picture in a couple of slides, and you will see. But it's so much important in this case. Without the ultrasound, we wouldn't diagnose the patient so much easily. We went to CT and then we called like a pulmonologist, but with ultrasound, we diagnosed it so much easier. So that's a good thing in this case. Also about the heart, how we differentiate between the cardiogenic edema and non-cardiogenic edema in this case. BNP was high, but it's not a heart issue because, as I said, if it's lower than 300, so we cannot go with the cardiogenic edema. And also the physical examination was also normal, so that's an important thing. Take care of this always when you see picture looks like heart, think about the lung because maybe it's only a lung issue, it's not a heart. So an echo will help you, and also BNP will help you in this case. And oh,
What about the right bundle branch block? We just forgot about it.
yes, that's actually a good question. Right bundle branch block. Maybe that's like a masking of the lung disease. So like let's say if you have a COPD, if you do an ECG for COPD, sometimes you will see this picture, but there's nothing with the heart because of the overload of the fluid between the lung and the heart. It will show you a picture of like a right side heart failure. But how can you confirm this by echo? An echo showed the normal heart, so we cannot say that they have an issue with the heart. So maybe it's like just in a specific second once you took the ECG, it shows the block of the blood. You have a question? It's okay. And empiric antibiotic, as we said, they start with the azithromycin. It worked here, but what if it didn't work? We should start with something more empiric, more wide spectrum. We should cover like a Legionella. We should cover like Pseudomonas. Start something more, yeah, Ceftriax and Cefepim, Piperacillin and Tazobactam. Then we change according to the culture, or according to the sputum, or according to the serology. I think they started azithromycin because they already had the serology ready, so they just went with azithromycin. Azithromycin is used for the community-acquired pneumonia, which is like a lobar pneumonia. But here we have atypical picture, so it could be a virus, it could be like influenza, it could be like I don't know, like an RCV, and there's no fever. So this is put us in the virus way. So we should start wide spectrum to cover all the stuffs. Then according to this, then we go more slower according to the sputum and to the culture. That's also not something. And serology versus PCR. I think we discussed this. PCR is like more faster than a serology. When I read this case, they waited around 3 days in the admission waiting for the serology without any like treatment for 3 days. Only giving the fluid and CPAP, and that's not good. PCR will give you, yeah, it's sometimes biased, but like it will give you like a hint if it's bacterial, or if it's virus. So PCR should be the case here. And the rule of CT scan was the diagnosis here. CT, like for example, in those cases like interstitial pneumonia or also interstitial lung disease, they took a lot of CTs in the follow-up. And here comes the rule of the ultrasound. Ultrasound can take the place of the CT in this case. So we don't do like CT every couple of days trying to see if the patient is getting good or not in case of his lung. So that's why this, I think, this case is so much good. So like show you the rule of ultrasound. Okay. And the last question is about the generalizability. The generalized here means in like a research that this is like only one case. So you need to see a lot of cases to give it to give like an opinion according to the treatment and also the follow up. Because maybe this is only like one or two presentations. We have a different of cases with like a typical pneumonia. Some of them they show fever, some of them they're not. So you need to dig more to do like more research to see which like modality is good for treatment, which one is good for follow up. I'll wrap up with a quick talk about interstitial pneumonia. I believe it's important to talk about it. Interstitial pneumonia, it's a form of pneumonia invading the lung interstitium. As we said, it's only covered the pleural, not the alveoli itself. It's like it's outside of the alveoli. If it's in the alveoli, then we call it a lobar pneumonia. Uh, as we said, the difference, they're commonly caused by like an atypical bacteria or viruses. The bacteria we already mentioned, mycoplasma, and also Legionella and chlamydia. The viruses are influenza, COVID 2, and also COVID 19, and RSV. And the RSV, that's a respiratory syncytial virus. It's only in children. We don't see it in adults. It's around age 1 to like an 18 month. Usually, we don't see this in adults. The non-infectious could be interstitial lung disease. So you could have a COPD, and COPD lead to interstitial lung disease, or you could have like an ARDS, especially like in patient with an infection, or like a patient who had, let's say, a COVID, and then from COVID they got to a picture of ARDS. So over the ARDS will come interstitial pneumonitis. So this patient is so much, but we saw a lot of cases in uh, in the pandemic days. So that's why we give a vaccine even to the people which is they're not a high risk, because we are afraid of those patients. Okay. The clinical symptoms, um, we said progressive shortness of breath. We have a tachypnea, hypoxemia, which is we saw all of those in this case. A dry or like minimal cough. We didn't see this, and fatigue. We don't see fever here, which is weird. But that's why they call it atypical pneumonia. Fever is absent, especially in the elderly patient. Symptom may be severe despite the minimal chest X-ray finding, especially in this case. She was 87, so we saw a bad, actually my bad symptoms at the tachypnea and also at the dyspnea. That's why she came to the emergency. And can mimics the heart failure, which is we discussed already. Physical examination, signs of respiratory distress. We saw all of this, increase the respiratory rate. Also, the lung auscultation, that's an important one, a fine by basilar or diffuse crackles. That's very important because that's how you can differentiate if it's lower or or atypical, and it will guide you with a chest X-ray also. The cardiac examination is way normal, as we saw, and peripheral edema. Sometimes we see it, so don't think only about heart. Think about lung. Edema could be heart, could be lung, or could be something else. Like what? Do you have any ideas? If you see a generalized edema,
So yeah, kidney nephrotic.
kidney like what?
Nephrotic syndrome.
Nephrotic syndrome. The diagnosis, we do an X-ray. We saw a diffuse interstitial or like a reticulomodular pattern, which is we will see in the CTs. We had also we said that's actually let me say have a low sensitivity. So it could be a lot of stuff. It could be a lung fibrosis, could be like an atypical pneumonia. So you don't only rely on it. You need a CT with it. CT will show you the ground glass appearance. Still, that's not for the only atypical pneumonia. So you go with the whole picture, with the fever, with not, and according to this, you will diagnose the patient. But ultrasound will play a role here. You will see diffuse B lines, which is still still within its mastoid, and the regular thickness of broad line. Also, we mentioned this and useful for the bedside. So here are the pictures. Uh, this is the CT, and here actually you go with the X-ray. The first thing first of all, you always go with an X-ray. An X-ray here you can see the bibasilar. Actually, my picture kind of like an infiltrate in the both lungs. it will look more like an influenza or like my corona. Even sometimes like my ARDS could look like this. So if you have in the history something picture you to ARDS, think about it also. CT, that's a high specific here. This is what we call the tree bud or the tree bud. It looks like a tree bud if you focus here.
I don't know the one.
The mouse not working. Wait one second. What about now? Yeah, if you see here, that's the tree bud. Okay, that's a highly specific for like interstitial pneumonitis. So if you see this, you are lucky. Also, it's here.
Bronchogenic pattern.
Yeah. Also, I think you can see it here. Here also. This is called a honeycomb.
Honeycomb, I was gonna say, isn't that interstitial fibrosis?
Yes, the left one is honeycomb. This one is a honeycomb, which is could be seen in like COVID, in like a lot of diseases, interstitial pneumonitis. Also, could be seen in influenza. And if you want to see the obesities, you need to decrease the like when you start doing the CT, you need to decrease the contrast, so you see it more clearly. Here comes the ultrasound. The interesting thing, that's the abnormal here, and here's the normal. That's the B line. You see it? Well, we as a physician, I don't think we have like we have a good Mediterranean. I mean, I'm expert using the ultrasound. So most of the time, it's used by like a radiologist or like a nurses. So you won't be like the one who doing this. But it's so much more interesting that you can only diagnose a patient by using ultrasound without like a radiation, without a CT, without an X-ray. It's so much faster. You just bring ultrasound, and even it give you a good like a prognosis. You see it like a follow up. So that's something interesting. Okay. Uh, moving with the laboratories, CBC, we already mentioned. In CBC, we will see the WB cell will be normal in this case, which is not atypical. CRP and ESR, we prefer CRP better because it will show the infections more. The ESR is more for inflammatory process. So if you think about rheumatoid arthritis, lupus, or like anything related like to like rheumatology, you will do an ESR. CRP is mostly infections, bacterial, viral. If you think about parasites, go with an eosinophilia, which is will show in WBC, okay, and CBC. ABG is so much important, and most of us we miss this. We go with an oxygen, we order CBC and CMB, and we miss the ABG. Always order it in case of lung or heart disease, order the ABG, or also sometimes the kidney, because you want to know what is the issue here. Is it the kidney? Is it the lung? Is it the heart? So it will guide you in this case. We saw respiratory acidosis, so it goes. Um, it goes with the lung issue. Blood and urine cultures, also serology and PCR. It's for the typical organism. Here we got the chlamydia only. The treatments, as we said, we start with a supportive therapy, oxygen therapy. We start also with a CPAP. Sometimes you will do a BPAP also, which is a more advanced than the CPAP. Okay, the mechanism is kind of different. Careful also fluid management. So most of the time, once a patient presents us to the clinic, we start with an IV fluid. In this case, don't do this because you may kill the patient. You already have edema and you're giving a fluid, so you overload over the heart. So don't do this. Take care here. Etiologies: atypical pneumonia. If it's already confirmed, you start with macrolide, azithromycin. Usually we do this in case of like a community-acquired pneumonia. Doxycycline, that's more wide spectrum. And the best one are fluoroquinolones, like ciprofloxacin. So I like whenever I see a case, I start with the ciprofloxacin. It's more better. I mean, it will cover all the stuffs, and then according to this, I will go with it with more lower according to the culture. The treatment depends on the severity, but most of the time it's 2 weeks in case of pneumonia. Sometimes we only treat 1 week, and then we do another 3 days if the patient still didn't get a good. I mean, the condition is still bad, but most of the times they continue as a 2 weeks. A follow up, we used also the APGs, and ultrasound has a role here. The need for the repeated CT and radiation. To take home, we have interstitial pneumonia, so we can present without fever or leukocytosis, so take care of this. Elderly patient may have an atypical picture, especially this one. A lung ultrasound is so much superior in this case, which showed us a lot. And early diagnosis and targeted treatment is good for the outcome. Thank you all for attending. This is the references.